So now we're moving on into our T cell mediated type 4 delayed type hypersensitivity diseases. And so, as we know, we have Th1 cells that are going to mediate inflammation. So the classic definition of our delayed type hypersensitivity is that it's going to take place within 2 to 3 days after antigen. So this is going to be primarily a Th1 response. Some can have some Th17 influence, and it's going to take place 2 to 3 days after antigen. And the TB skin test is an example. Now we have some pathogens that are going to induce delayed hypersensitivity. We have Hep B and TB. And TB will have granuloma formation plus cell death plus caseous necrosis. That looks like cheese. We also have environmental, and these can be nickel, which is going to have contact dermatitis. Or we can have something like haptens, such as cosmetics or poison ivy. And they are typically low molecular weight. And they don't cause an immune response themselves, but when they bind to a host antigen, they make them both look different, and then you have a response. Okay, so we have our Th1 response. And so typically you're going to have a memory response. And you're going to have your CD4 T cells that are going to be activated, and they're going to go back to the tissue and stimulate your macrophages to respond to the potential threat. So, for example, you have a skin, and you have your poison ivy. And you're just going to cause poison on your skin, and then the hapten enters the skin, crosses the skin into your body, and then you have an epidermal protein. And this epidermal protein is going to bind to the hapten. And it's going to look like an antigen. So it's thought that maybe it triggers a toll-like receptor. So here's your macrophage. Here's a TLR, maybe. But it gets activated. And then, of course, you have your resident dendritic cell. Make them green. And this will go to the tissue, or it's a draining lymph node. And this will activate your B cell. Sorry, CD4 T cells. And then your CD4 T cells will go migrate back to the tissue and will help the macrophage through cytokines, and then you'll get a delayed type reaction on your skin. So your macrophage plus your CD4 will stimulate each other, and TNF causes much of the damage in this type of reaction. So there's also rheumatoid arthritis. This is going to be associated with HLA-DR4. You can treat rheumatoid arthritis by targeting TNF, those monoclonal antibodies. So it's TNF, IL-1, IL-6, acute phase response. Because basically the antigen doesn't go away, so you can continuously have triggering of the acute phase response. And in this case, you have the synovial membranes. And of course, these are lining the joints and tendons. They are going to swell and become disabling. It can also impact lungs and your skin and your eyes. It's going to be a Th1, Th17, TNF alpha are all going to play a role. It has unique antibodies. You have the antibodies are going to be anti-CYP-related peptide antibodies. And you're going to have, and these CYP-related peptide antibodies are going to be diagnostic. You also have rheumatoid factor. And this is going to be anti-IgM plus IgG antibodies. Now, what's going to happen here is you're going to have IL-6 and IL-17, and these are going to damage the synovium. And it's going to lead to osteoclast, and the osteoclasts are going to be active and damage bone. And this is going to lead to erosion. Now you have autoreactive T and B cells. That are going to recognize the citrulated proteins. And then you're going to have IL-6 persisting as an acute phase response. And this leads to fatigue, weight loss, elevated C-reactive protein, liver influence. Now, the protein citrulation is basically you have the amino acid arginine, and it's going to be converted to citrulline. It is thought that this may occur during inflammation. So you can have some sort of infection, porphyromonas infection in the mouth, or you can have smoking, which is in the lungs, of course, or other unknown factors, and then you can generate antibodies to those citrulated proteins. And then if you have the particular HLA phenotype plus other factors, this can lead to Th1 and Th17 cells in the synovium, and this can lead to the symptoms of the actual disease. It's thought that about 1% of the population in the United States suffers from rheumatoid arthritis. Another type 4 is going to be multiple sclerosis. This is a chronic disabling neurotic disorder. Disabling. Write that again. Okay, so in the early stages, you're going to have formation of demyelinating plaques. In the CNS, and you can repair these. And in the late stages, you're going to have extensive axonal loss. And this cannot be reversed. And so this is going to be linked to location as well as infection. So if you live further from the equator, the incidence increases. And some infections are measles and EBV. Measles creates similar lesions, and EBV infection has several effects on the body. And then the T cells, this is a type 4 reaction, so T cells are going to mediate most of the damages, but it's thought that and the antibodies are going to be important for the diagnosis. So it's thought that your T cells are going to be responding to antigens like myelin, basic protein. And then the macrophages are going to move in and going to translate, inhibit signaling, but this is going to be reversible. And then locally produced antibodies against those myelin basic proteins can also damage myelin. And then your macrophages are going to cause irreversible damage to the myelin sheath. And so one of the things that's important about this disease is that in a MS patient, you have a variety of antibodies. So this looks very variable. serum antibodies. And this, in a person that's normal, it's very uniform. Not as variable, not as many bands. So again, treatments are to avoid triggers such as poison ivy. And then if you have an endogenous source, of course that will not work. It's more autoimmune. You can have anti-inflammatory drugs. You can use aspirin, ibuprofen, indomethacin, and these are going to all decrease arachidonic acid metabolites. We also have the corticosteroids, which is going to decrease gene transcription. It's going to bind to regulatory regions of the DNA at low doses. At high doses, it's going to impact cell signaling. The side effect, of course, is going to be immune suppression. It has the greatest impact on phagocytic cells. And it's too toxic to use for long term. And then we also have blocking of cytokines. And the targets are going to be IL-1, IL-6, TNF, and CD80. Okay, so an overview of immune-mediated drug reactions. We have our different type 1 hypersensitivity reactions here. So for type 1, we have our anaphylaxis and specific IgE tests. For type 2, we can have drug-induced hemolysis. We can use a Coombs test to test for that. We have type 3, which is the Arthus reaction to vaccines. We can look at antibody levels. Circulating immune complex is serum sickness. Again, we can look at antibody levels. And then contact dermatitis, you can look at patch tests. Just a quick overview of type 1 hypersensitivity. These are typically going to be harmless. You won't make a response to that. If it's going to be very annoying but not life-threatening, you're going to have hay fever. Typical causes are going to be environmental, pollen, grasses, things like that. And you're going to get a local mast cell degranulation, typically in the upper respiratory tract. Peanut allergies are going to lead to a more severe infection systemically. Latex allergies are going to be localized and can cause irritation of course, skin. All going to be caused by IgE, release of mediators by mast cells. Type 2 hypersensitivities, we have alloantigens, as well as environmental antigens, as well as autoantigens. For alloantigens, this is going to cause blood transfusion reactions or rejections, and this is going to be ABO, is going to be the antigen typically in target. Even though it can be a rhesus, the more dominant is going to be, of course, ABO. You want to have matching of that, but you also want matching of rhesus. The innate involvement is going to be complement. You're going to have IgM associated with this. It'll be your natural antibodies. And so this is the T-independent antigen, so no T-cell involvement. Another antigen is going to be a rhesus antigen, and this is going to cause hemolytic disease of the newborn. This is going to be mediated by macrophages. It's going to have IgG, and so this is a Th1 response. Drug-induced hemolysis, this is where you have penicillin. That's going to bind to the surface of a red blood cell, and this is caused by a macrophage going to eat those red blood cells due to opsonation of IgG and Th1 again. Graves' disease is a agonist antibody binding to the thyroid stimulating hormone receptor. This is IgG and Th1 response. Type 3 hypersensitivity or immune complex, you can have environment, pathogen, or autoantigen. Environment substance can be farmer's lung. These are mold spores. You're going to use complement as well as neutrophils, and this is a Th1 response, IgG. Post-strep glomerulonephritis is going to be caused by streptococcus infections. It's going to involve neutrophils. You're going to have rheumatoid factor, anti-CCP involved, as well as the Th1 and Th17. Systemic lupus, DNA is going to be a target. We're going to have macrophages, have antibody production, Th1, Th17. And finally, type 4, we have rheumatoid arthritis. We're going to have citrulated peptides as our target, anti-CCP. We're also going to have rheumatoid factor, neutrophils are going to be involved, Th1, Th17. MS is going to be, myelin is going to be the target, antibodies are going to target that. Macrophages are going to do permanent damage in the later stages, and this is Th1, Th17. Type 1 diabetes, pancreatic islet cells are the target, beta cells. We're going to have Th1 response, and we're going to have antibodies going to be produced. More diagnostic, can do some damage, but it's really the T cells that damage. We have autoantigens to food, that's a celiac disease. We have our gliadin, which will become an acid, and that's going to trigger a Th1 response. And then we have also environment antigens that can cause contact dermatitis. We can have weeds and other things, and this is going to be a Th1 response. And that is the end, dropped my pencil, of our hypersensitivity reactions.